Hello, everyone, and welcome to the Medical Fitness Podcast. I'm Jeff Young, and in this episode, I'll be speaking with my co host, Dr. Thomas Hammett. Our podcast is brought to you by the Medicine, Rehab, and Fitness Institute and JY Kinesiology LLC, both of which are dedicated to medical fitness education and building the bridge between medicine, rehab, and fitness. You can learn more at mrfinstitute.org. The purpose of our podcast is to provide you with principle and evidence based content on all things related to exercise science, strength and conditioning, medical fitness, and building the bridge between medicine, rehab, and fitness. In this episode, Thomas and I discuss the importance of exercise within the medical plan of care and why it should include referrals to qualified fitness professionals. This is a unique opportunity to listen to a seasoned clinician and a seasoned exercise specialist discuss bridging the gap between medicine, rehab, and fitness to include patient referrals and programming. We discuss topics like how do clinicians make the patient referral to fitness professionals, and what does the exercise prescription and plan of care look like? What do we mean by medical plan or plan of care following the patient visit, and how can we use it to catapult the patient into exercise? In the plan of care, what is the difference between including physical activity and exercise? How do the prescriptions differ from each other? How can clinicians make it easier to collaborate with fitness professionals and refer their patients? And how can we overcome perceived barriers to referral, such as lack of time and lack of money, which tend to be the most common barriers? So let's get started, and I hope you enjoy the conversation. Okay, hello everyone, and welcome to another episode of the Medical Fitness Podcast. I'm here with my friend, colleague, and co-host, Dr. Thomas Hammett, and we're each other's guests today. So we have a great topic that I'm actually going to allow Thomas to introduce here and get the podcast going. But welcome, Thomas. I'm looking forward to our discussion today.
Yeah, for sure. Yeah. And we are doing something a little bit different today, but I think, was really when we started this podcast, Jeff, something that we intended to do in the first place, right? Which is we have this set of topics that you and I in particular in practice know that we've dealt with, right? And so we're going to take some time to chat with each other. We've actually had a number of conversations off air around some of the subjects that we'll talk about in future episodes, including today's episode, which really is going to be focused on thinking about the plan of care, both the short-term and the long-term plan of care from a medical perspective, and how we can lead the appropriate patients to a medical exercise plan and what that looks like, how we make that work. So today's conversation isn't revolving around a guest. It's really revolving around the topic, which is, how we make that referral or prescription, and what does that medical plan or the plan of care look like in order to facilitate that happening. So you got anything else you want to add?
No, other than to say that I'm really looking forward to this because you're exactly right. We have discussed this topic many times, and there's been a bunch of times since we live across the country from each other where we're on Zoom and we've said, I wish we were recording this. This would be good information to get out to, the public. And so now here we are with a podcast and have this opportunity. So yeah, I'm looking forward to it.
Yeah. So, so a conversation that we had on the phone yesterday when talking about this subject between you and I, we really needed to clarify what is a medical plan or what is the plan of care. And there may be fitness professionals out there listening to this who are trying to get into this world that may not realize that this is the like the gateway or where the prescription is made, that there's actually a section of both, dedicated time in the visit and the documentation that's dedicated to what happens after the visit and what is the plan for a patient related to their condition that they present with, to addressing whatever issue it is that they're presenting to the medical provider for. So really this is revolving around how does that catapult people into exercise? And so I'm going to jump right into questions. We're going to do this in maybe kind of a popcorn format. There may be times where, you decide to ask me a question too in this. So let's just jump right in. But the first question I want to ask is, So in that medical plan or in the plan of care, Jeff, is including exercise different than including physical activity? And if so, what's the difference? And maybe can you share a little bit about like what a prescription or a recommendation of physical activity looks like compared to a prescription or recommendation for prescribed exercise? Like how would that sound different or look different to you?
Yeah, and I also look forward to your input is this in this topic as well. So when you ask me that question, the first thing that comes to mind, which you and I have talked about a zillion times, and we're both passionate about, is that move more versus exercise continuum. And I wish I had a little like visual in front of me that all the listeners could see, so that you could really like picture this continuum. When we're talking about moving more formally, that's actually non-exercise physical activity. So the continuum includes exercise, which is defined as a subset of physical activity that's planned, structured, and repetitive, and has a final or intermediate objective of the improvement or maintenance of some aspect of physical fitness. So exercise is a much more structured and purposeful, and there's an intent to it to either improve or maintain fitness, whereas non-exercise physical activity, or in other words, just moving more, is referring to just moving more, where you're just getting your body going. And so, part of the way I would answer your question is like the verbiage and how you would differ the verbiage is with moving more, that's going to be your standard and stereotypical advice to park further away from the store and carry your groceries, take the stairs instead of the elevator or escalator, things like that, and walk more, things like that. So I want to make it clear to the viewers and the listeners that if there's one thing I am not anti move more. I might sometimes sound like it for those of you who follow me on social media, but I'm really not. It's unfortunate we even have to really recommend this because in human history, we have always moved and farmed and stuff like that. So I think it's unfortunate. But I'm a huge fan of moving more and all those things. But I'm arguably a bigger fan of exercise. And I just don't think it's enough to include moving more as like your only exercise prescription, your only advice. And it just happens to be very common in the medical world to just kind of give that advice with no real structure to it. No. So now let's jump over to the exercise side. Exercise was built on the foundation of many principles, and one of the most common that most people know is the principle of progression and actually the principle of overload. So progressive overload. So that's the part that Move More doesn't typically have. Moving more is great. It's great for your health. We need to do it, but we really need that structured exercise. So my last part, at least for now, to answer your question, when it comes to verbiage with exercise, that's where, like with aerobic exercise, for example, we use what's called the FIT VP principle, where it's an acronym where the F stands for frequency, the I stands for intensity, the first T stands for time or duration, the next T stands for type, the V stands for volume, and the P stands for progression. And when you fill in those blanks, you've literally just designed a program for yourself. And then with resistance training, although you might see in some literature that it'll follow a fit principle, I'm not a big fan of that because with resistance training, there's way more variables. It's how many sets do I do? How many reps? What order of exercise? What's the exercise selection I should choose? You know, how close should I take a set to muscle failure? How many sets should I do in a week? Et cetera, et cetera. So there's a lot more variables. But the point is that the verbiage is definitely different. And the verbiage with exercise is a much more structured type of verbiage. And I just think it's important. Another reason why I'm glad that we're having this discussion is because, and I'm glad that you really started off with what is a medical plan of care and kind of talking about that, because it kind of points to the fact that one of the reasons why there's a disconnect between clinicians and fitness professionals is we don't speak the same language. And from since I kind of represent the fitness side, we need to learn the language of medical professionals. But then, vice versa. Clinicians need to understand stuff that we're talking about right now, and that there is different verbiage, and that there is a continuum of move more versus exercise, and that we do need to try to suggest exercise, structured exercise to patients whenever possible. So I could keep going, but I'll stop there and let you chime in.
Yeah, well, and so what I might do too, Jeff, is start with like if we're visualizing, I'm going to try to paint a picture of the move more continuum. And if we're picturing, imagine putting every person in the United States on this continuum, right? And on the far left side of the continuum is completely sedentary, not moving at all, doing absolutely nothing. And on the far right is doing some form of progressive resistance training program, meeting your cardiovascular guidelines, generally exercising at a level that we would consider to be like medical grade exercise even. So consistently progressing, consistently reviewing, consistently changing variables in the program to get the benefit that you're trying to get out of your exercise. And somewhere in the middle of that is a group of people that are moving, that are maybe physically active at some level, but aren't quite to the far right where people are exercising really consistently and at a high level, or they're not quite to the far left where people are completely sedentary. And we know that most people fall somewhere right in the middle of that, right? Most people aren't completely sedentary. Most people aren't doing a prescribed exercise program. They sit somewhere in the middle. And, I think what you're pointing out, Jeff, is that when medical providers make that recommendation to move more, or to be more physically active in an unstructured way, I think there's a point of diminishing returns on that, right? Like you can get a little bit more fit by walking up the stairs. You can be a little bit more fit by walking to the store instead of driving there if you're not currently doing that, right? But there is only so much benefit you're going to get from doing those kind of activities before if you have a medical goal, or if you're trying to work on a specific condition, for example, that's taking the stairs probably is not a structured enough plan, and it doesn't have parameters of specificity to say that that's going to be the treatment for you. That's going to be a actual intervention to help you with your condition or prevent a condition for that matter. So when we think about including something in a medical plan of care, we want it to be more specific, obviously. And, I'll share a little bit about why I think medical providers make the recommendation of being more physically active instead of an exercise plan. If we're prescribing exercise as a means to avoid medication for a specific condition, or to reverse let's say hypertension or high cholesterol, or any number of metabolic factors that may be contributing to someone's poor health. Maybe we're doing it for stress management. There is so much more benefit to that progressive program that continues to grow with a patient as their body adapts to that exercise. Now, what I'll say about why providers make that move more recommendation is I think there's this element of one, like readiness to change. Like, is someone ready to make a change at the level of I'm sedentary right now and I'm going to go start a prescribed exercise program? Maybe that's a big leap. I don't know. And, as a provider, I might say, well, that's a lot to educate someone on the purpose of doing that. So I may just make the recommendation of taking, 10,000 steps a day, or I may make a vague recommendation of do high intensity interval training. I worked with a physician one time that sent a generic prescription to every patient in their after visit summary, or the printout that they got at the end of the visit, that said, do high intensity interval training for 90 minutes a day. And I thought that was a little bit much, right? And not very specific. And these people don't know how to do that, which gets into another question that we have. But this idea of move more, I think it really is like, it's that first step in the behavior change continuum. Can we get you to start doing something? And if we get you to start doing something, can we build on that, right? And, I think that is an appropriate place for some people to start. What I'll say is, if you have medical goals, doing prescribed or programmed exercise is the best thing you can do. like expecting medical results out of a non-specific, non-progressive program, it's probably just not what you're going to get. So I think that that's really, to me, the difference between prescribing physical activity and exercise. I'm with you, Jeff, though. Like, if somebody's totally sedentary right now and we get them to a place where they can start walking, or they are, doing their basic activities of daily life again, that's a big change. And that, that's something that physical activity can do for some people. So I think there's a point that can get you, but then for a lot of people, we need to take that step further and make that prescription for exercise. Can you maybe share a little bit more about what it looks like? You kind of shared, I think, a really good visualization of, okay, I'm a medical provider and I say, take the stairs instead of taking the elevator, or walk then 10,000 steps a day. And that may be a recommendation or a plan of being more physically active. What would it look like to make a plan of getting exercise instead? Like, what would be that specific recommendation that you would think of a medical provider giving?
Yeah, so I'll break this down into the two main components, that being aerobic exercise and resistance training. And I'll start with aerobic since that would probably be easier. And it goes back to that FIT VP principle that I mentioned earlier. And let me start by saying that I know a lot of clinicians, especially lifestyle medicine clinicians who are board certified, learn about the 150 to 300 minutes of moderate intensity aerobic exercise, uh, 75 to 150 minutes of vigorous intensity. And to be honest with you, I'm not the biggest fan of that because in my experience, I found that those numbers can scare a lot of people. People tend, not everybody, but a lot of people tend to have like all or nothing mind frames or mindsets. And so they'll hear something like that and they'll be like, oh, I can't get in 150 minutes a week. So from an aerobic standpoint, I'm a believer in first knowing that uh, acronym, FIT VP, and what it means and how to fill in those blanks. So some of it just means being educated on that. And then from there, understanding, like you said, just understanding the start point and finding out what the person is capable of doing, what they're currently doing, getting a sense of that, and then plugging in the answers to those variables. When it comes to resistance training, I like to break resistance training down and the programming for it into two categories: the initial program design, and then how are we going to progress from there. And I'm a big fan of, from an initial program design standpoint, of starting with something that mirrors traditional outpatient orthopedic physical therapy, starting them in their comfort zone, showing them that, hey, even with a light intensity exercise, you're going to be feeling better. Your joints are feeling better. You are getting moving now. And then slowly progressing from there in the form of phases.
Yeah. And, Jeff, I think your answer to that too, I could summarize really briefly in a refer to a fitness professional, right? Because I think any medical professional that's sitting here listening to this is like, wow, well, that does sound like the idealistic recommendation or set of recommendations for someone. And it'd be nice if I could go through, what do you have at home? What is your previous level of activity? Can I teach you intensity? But we know that in particularly in a physician's time allotment that they have and the things they have to manage, that ain't going to happen. And, if we know that someone is a good candidate for benefiting from exercise, making that referral, I mean, you can see just the value of what a fitness professional can give to the medical situation, which is the time that we don't have, right? Even speaking for myself as a PT, what Jeff's talking about is like, yeah, I get to start. Insurance will pay me to address an impairment in a specific body region. And I get to do that for a specific amount of time. And then it's done. And I get to do just enough to build confidence and introduce people to exercise. But so much of that stuff, Jeff, I don't get to get into with people. And there's so much value, after I'm even done with people, in moving into a program that looks at the whole body, that's more progressive after that, that's focused on overall health goals rather than a specific body impairment, and maybe also contributes to improving that body impairment over time, right? A lot of times PT gets people to 70 to 80% of their um, their goal for that body impairment. So how do we keep getting them progressing into maybe even before, like, more than they thought they could get back to. So, but really, like I said, if I could summarize everything you said, it's like, make a referral to a fitness professional. I'm curious, because this leads into the next question that I was planning on asking you. Maybe share a story, because I think stories in this situation are really impactful. I'd love it if you could share a story about the best method of providers used um, to make it easy for you to take the baton from them as they refer to patients to you.
Yeah, that's easy for me, and I'm actually going to go a little overboard on this one and tell maybe uh, I'll combine them, but I'm going to tell one or two more stories than just one. So the first thing that comes to mind is I was in the Mount Sinai Beth Israel system here in New York City for 10 years, from 2006 to 2016. And during that time, there were two physiatrists um, who really were my top referral sources. And they there was a lot of similarities and also simplicity with how they went about things, which is part of what I'm hoping that the listeners and viewers get out of this. That part of the answer to your question is that it's really simple to pass the baton. And I think part of the barrier again and the division between medicine and fitness is people tend to overthink it. The two of the things that, or some of the things that these two physiatrists had in common were that I think are important to mention were number one, they both resistance trained. One was actually a strength athlete. He competed in Olympic lifting nationally for more than a decade. And the other one was just a regular gym goer, but for many, many years. So the point is that they understood, they practiced what they preached, and they understood the importance of it. Also, one of those physiatrists was the on the board of directors for the Medical Fitness Association for 6 years, and he actually started their physician track. He was the medical director for this facility that I worked at. So this is just another example of someone who, like, he understood the importance of the big picture and medical fitness and the need to refer. So I guess part of what I'm trying to get across here is that they kind of got it from an exercise standpoint. It was easier for them to advocate for it because they did it. They understood the need for this continuum and to move patients on into fitness and wellness and especially resistance training to get them stronger. So so they made it easy to in that passing the baton because number one, they got it and it was easier for them to talk about it. One of them I worked with on site, so saw him pretty much every day. The other one worked in a different facility, so we mostly communicated through text, email, phone. We worked out with each other on occasion, but I didn't see him on a daily basis. So that was a big difference between the two, which is part of the reason why I wanted to combine this story because the one that I saw every day or nearly every day, he did a great job, masterful job of talking to his patients in his treatment room and then about my services. And let me also add that another important part of this that I don't want to forget is that they understood the services that I provide and my feed schedule. And I think that's really important because I've worked with many clinicians, to be honest with you, most clinicians who didn't take the time to learn the services I offer and the fee schedule. And that's another barrier to referral. You need to know the services your professionals that you refer to, you need to know their services. So in any case, um, they knew that, they advocated for it, they practice it, and so the one that I worked with um, in the clinic and saw him on a regular basis, he did a great job of introducing me to the patient face to face whenever possible, and uh, and it's all about trust. So he would, both of them would talk me up, uh, pretty much as though I'm a no-brainer. Jeff's a kinesiologist. He's medically trained. So basically, just again the verbiage and getting the patient to before they even meet me to have some level of trust for me because of the wording that the clinician is using, and for the clinician to understand the power that they have above and beyond just motivational interviewing concepts. Things like this, it can be really motivating. So they were really good at that. The one who I didn't work on site with just did a really good job of talking me up, making sure they understood that I was needed to be there, that I needed to be part of their long-term plan of care. Even if that was just to get them started on the right foot and then occasional check-ins. So it didn't necessarily have to be that they train with me for the next 6 months or year or 5 years of their life, but that they at least needed to connect with me so that I could put them on a properly designed, clinically safe, individualized progressive program. So they made it so easy to that passing the baton because of all those things combined and really getting that trust level up. And I wanted to say two other real quick things. One of our colleague, Sheila Aubois, physician assistant, and she refers patients to me virtually. She also just does a really good job of talking to the patients about lifestyle medicine and the exercise pillar within lifestyle medicine. I have put her on an exercise program, which is another important part of the answer to this question because she experiences my philosophy. She's been on my exercise program for a couple of years. So other advice I would give to clinicians is get get to know not just the philosophy and fee schedule, but train with your trainer if possible. So you can understand how they go about consultations, that initial program design, how they progress, etc. It makes it so much easier for her to talk to her patients and to motivate them because she can talk to them about the benefits that she got from the program that I put her in. And then she also is just really, really good since the referrals come through email. She just has a really simple script that she uses for pretty much every single patient. When she refers them to me through email, they all say pretty much the same thing. Jeff is the medical fitness expert I talked to you about. I'd like to introduce you to each other. It's a really easy process. It's just a matter of understanding how to do it. And the last thing I'll say, back in 2015, I presented for the first time at the American College of Lifestyle Medicine's annual conference in Indianapolis. It was a co-presentation. And one of the presenters, and I'm going to butcher his last name. I don't know how to pronounce it. It's like John Cirilli or something like that. But at the time, he was on the board of directors for the I'm sorry, he was the chair of the board of directors for the Medical Fitness Association. And part of his presentation, which was gold, was that you can have the greatest facility, with the most beautiful equipment and the most talented trainers and the most competitive fee schedules. If you don't hire a staff that is bought in and clinicians that are bought into this, then the medical fitness facility is going to fail. And he's exactly right. That has been my experience. I've worked on both sides of the fence in both hospital settings and private practices where the referral model was either built into the system or it wasn't. And where it was built into the system, those models were successful. And where it wasn't, the clinicians struggled with referral. So to summarize my answer to your question, it's passing the baton really starts with uh, being able to sell it easily because you do it and you can and therefore you advocate for it. But you've gotten to know your fitness professional referral source to some level, their fee schedule, their philosophy. You've trained with them at least a little bit so that you have experienced it, which makes it easier for you to sell and be excited about selling it. And then it's literally just a matter of talking them up. It's honestly that simple. Just talk them up, and understand that the power you have in your role to move that patient from, whether you're a physician, downstream to physical therapy, maybe for as a first stop, and then the physical therapist to the fitness professional, or whatever the case may be. But it really just isn't that hard once you understand basically the components that I just talked about.
What's interesting about what you mentioned, Jeff, I didn't hear you one time say that the providers that set you up best were the ones that convinced people that exercise was valuable for them, right? Like that they didn't educate them the best, I guess is maybe the best way to say it. Like
Yeah.
maybe they did convince people that exercise was valuable to them, but really it was more of at a patient provider level in that conversation between the patient and provider. It was a conversation that included action and included knowledge more of a fitness professional services than about periodization and
Exactly right.
how exercise works. It feels like that stuff is less important.
It's exactly right. You nailed it. And there's not actually a whole lot to add, but I'm glad you said it because I think in my experience, and again, I almost feel like I'm bashing here, but I'm honestly not trying to bash. I'm just telling the truth from my experience. But it's that clinicians tend to want to take on more than they need to. And what they need to do is learn the language. So it's really good to learn some basic exercise science, some strength and conditioning principles, the fit principle, because that way it's going to be easier to speak with your patients about it. But it's not really your job in most cases, are always outliers. But generally speaking, it's not the clinician's job to set them up on the program itself. That's what our job is. And so that's exactly right. In my experience, the best referral sources were the ones who didn't try to prescribe, but instead understood the importance of me in the continuum of care and the importance of what needed to happen to talk me up and talk my services up and talk the benefits of exercise and what I can help um, provide them and guide them on. Uh, so really, it's honestly that simple.
Yeah. So that was like the provider patient level of what I took from your answer, which is really important, I think. And I agree. My experience in referring patients to fitness professionals, we have a pathway within our clinics, both that utilizes fitness professionals within the physical therapy plan of care and a service we call Bridge, and a post physical therapy discharge program that is a prescribed exercise program with a fitness professional. It's called Lifestyle 365. And, you know, me being able to describe in depth what the exercise service, why they needed, how about this? Why they needed the exercise service was far less important than creating a knowledge of trust and a awareness of the services and awareness of the value of what those services are, of how that fit for that person. So it took, a lot of it was, do I know enough about this person from my subjective questioning from, the initial interview that I did, to know what they're trying to get out of seeing me as a PT, and can I connect that to exercise. And sometimes those programs were not the right programs for them. I didn't blanket refer everyone to an exercise program. Some of my patients were 17-year-old kids that are doing gym programs with their school and their football team. I'm not going to tell them to do a medical exercise program in our clinics because they're doing what they need to be doing. But for the people who identified that I identified as people who could benefit from exercise, who maybe themselves are identifying that they have a goal of greater health or feeling more fit, of being able to do more, a short-term plan of care wasn't what it took. And rather than trying to convince them of how great exercise is, I talk about the service and talk about the people. And of course, exercise comes up as, like, tell me how this is going to help me, but it is not the primary focus in most of these conversations. So at the provider patient level, that is the conversation. I agree, Jeff, that has been my most effective method. And then, you're talking about it, a system, or like, whether you're a clinic manager or a director at a medical system, what's the lens that you can look through, or what you can do to help build a system that refers to exercise professionals. And it's a culture of, you pointed out that the people that exercise are the best referrers to exercise because they inherently understand the value through their own experience. And if there's a culture of that within the workplace, that is a huge advantage. I'll just say straight up, it's a huge advantage if your staff are exercising. On the other side of it, it's some level of accountability. Those referrals to exercise, that kind of stuff is more important than, do you understand why we refer to exercise? Of course, that's important, but the other stuff, the system stuff is it is really just as simple as, are we holding staff accountable to this when their patients come in and present looking like they would benefit from it, they want it, and we have a chance to make that happen for them. So this, I think, leads into a good additional question. And it may need to be one of our last one or two questions here. But, this is maybe more of a nuts and bolts question for you as someone who would receive a referral. So let's say I refer a patient from my physical therapy practice. I decide that they are a good candidate for a prescribed exercise program. So I make that referral to you. What kind of information do you want to know? Or maybe even better than that, what's the bare minimum that you would want to know to get started with working one of my patients, Jeff?
By the way, most people looking for the services of a fitness professional are really just looking for information on how to get started on the right path, not to pay for training sessions every week for months or years on end. For the 60 to 70% of people with chronic disease and or joint pain, they're also looking for someone who can help them develop a clinically safe, individualized exercise program that takes their conditions into consideration. If you're interested in getting yourself, or for clinicians, your patients started on a safe, cost-friendly medical fitness program, you can find more information about the virtual services we offer at mrfinstitute.org/services. We staff only degreed kinesiologists and exercise physiologists and will work with your healthcare providers in the design of your exercise program. For the clinicians listening in, you can add this virtual service as a reduced cost option for your patients. Check out our website and send us an email, and we'll give you the details about this unique and much needed service. Yeah, so I'll start by saying that when I first started in this Mount Sinai system, I didn't have a clue how to what questions to ask, how to collaborate with physicians and allied health professionals. I was scared. And part of the reason why I avoided asking anything, at least initially, is because I didn't want to look stupid. But I started to notice over the course of time that, again, the answer to your question is pretty simple. It's really just kind of like for instance, so again, if you refer to patients to me, after thanking you for the referral, I would just ask you, what do you want me to emphasize? Or in other words, what are the indications? What do you want me to avoid in the programming? Or in other words, what are the contraindications? Do you know of anything that this patient is apprehensive about? And really, other than that, just is there anything else you would like me to know about this patient, whether it's psychosocial issues, financial issues, travel issues? It's really as simple as that. And I found that in nearly every case, clinicians have no problem filling in those blanks.
Mm-hmm. Yeah. And I mean, even at whatever level you can get that kind of information, what's nice, Jeff, is that as you work with someone longer, right? Like the fitness professionals that I worked with for really over 6 months, they start to learn a little bit from me about, okay, I get this kind of referral. Really the question that I need to ask at that point, because I've received enough of Thomas's referrals that I kind of know what he wants us to do, is are there any exceptions to the rule, right? Like I've seen enough of Thomas's patients. I know why he's referring this person to us, more or less, right? It's to do this program or to do this service, to focus on these things. But is there any contraindications to doing that thing? And it's really nice to get to that point with someone, right? But at first it is tell me a little bit about what you're hoping to get out of this. And the first time you refer to a fitness professional, it's kind of a delicate situation. You want to build trust. You want to know, what the goal is that you're intending to have from exercise for that patient. So, it's important to get that bare minimum information. Is there anything you want to add to that?
Yeah, there is one thing. It's maybe a little off topic, but it relates to something that you just said. I've learned that another barrier to referral is again that trust thing. And I don't want them to hurt my patient, in any way, cause some sort of exacerbation or flare up. Well, part of the reason why I'm doing the things I'm doing now, and I'm here talking to you in this podcast, is because I had clinicians who saw early on my first week, my first several months in that Mount Sinai system, they realized that, this guy isn't as his skill set isn't what we thought it was. His
Mhm.
knowledge isn't what we thought it was. And instead of firing me or getting rid of me and finding somebody else, they took me under their wing and you know taught me the language that they speak. But another thing, and the point I'm getting to, is that they referred, for lack of a better way of expressing this, some of the easier. So in other words, it wasn't someone with more severe joint conditions, or stage 3, stage 4, or something like that, or basically things that are more on the severe end. They sent me someone with, for example, just general patellofemoral pain, or non-specific low back pain that wasn't so bad, things like that. And that's part of the way that they gain trust in me. And so I just want to point that out, because there are a subset of your patients that aren't going to be as challenging. I don't want to say easier. They're just not going to be as challenging for a fitness professional to put on a program.
So started with less complex, more straightforward patients, and then we're able to, yeah, sure. Well,
Exactly
and
right. Yeah.
medical providers love protocols. And what I'll say is that, in our clinics, we've gone as far as creating protocols. So one of the big challenges that we face, Jeff, in the state of Washington, and it's true across the United States right now, is that there are third-party um, insurance groups that look at my physical therapy plan of care and say, yeah, so I know that this person has a condition that you think is probably going to take 12 weeks to get better, but we're going to give you 6 visits. And so you got to do what you need to do in 6 visits. We may give you a couple more after that, but you got to convince us that it's worth it, right? And so what we're finding is that there's a lot of our patients that, ideally we would get them to a place where they are that nice and easy person to tee you up, right, Jeff? Like their condition is more or less, I don't know, not as flared up as it was before. I guess would be the way to say it, or the inflammatory phase of an acute condition is reduced or past, but we don't always get people to that point anymore. And we've developed some protocols, within our clinics that are, so if you're dealing with someone with shoulder impingement or a rotator cuff strain, or like even post total knee replacement, and we have a limitation on how long we're going to be able to see them, let's create a situation where it's known what the fitness professional is going to do at different phases. So if I have to discharge a patient in the pain reduction phase of their shoulder problem, at least it's known what I'm hoping is going to happen during that phase. And then you have an idea of what safe progression looks like. And, building those protocols has been something that we've slowly adopted over time, and I think is really going to help us. Something that I hope to share a little bit more with the public in some coming months and years here, but has been a really helpful thing for us. And I think that's one of those things where medical professionals feel a little bit more control in the situation when they get to say, hey, this is what I was thinking. It's laid out like this. I think time is a big barrier for medical professionals to lay this stuff out. So if it's something that they agree with, I think it's just nice to be able to use a tool like that. So yeah, I think maybe the last question I want to ask you, Jeff, before we jump off, one of the most common barriers to referral, and I would actually say it's easily the most common barrier to referral, and it indicates a lot of the things that you had talked about before not existing in terms of, do we understand the value of prescribing exercise? Is it part of the clinic culture? I see this barrier being the most common barrier in clinics that are struggling to find that identity, I guess, or to see that value in exercise. The most common barrier is a lack of time or a lack of money of their patients. The patient doesn't have time to do an exercise program, or it costs, whatever the price of the program is for you. Maybe it's $50 a session or $100 a session. How is a patient supposed to afford that? And I'm curious about, one, how you would address those barriers, and even maybe flip those barriers into facilitators if at all possible. But really maybe even just the basic, like, how do you address that situation with someone who's referring to you, or with the patient that's sitting in front of you?
Yeah, there's another thing where I just think that clinicians just need to be, it would just benefit clinicians to be better informed on the options. And the better informed you are, then the more you can discuss this with your patient, and let the patient know that, because I just think that in a lot of the mindsets of the public and with clinicians, is that exercise means like an hour session, for example, that it has to be an hour session, or that you have to do it 5 days a week. or there has to be a certain level of intensity. And it just doesn't. So, for example, there are a lot of people who have more time on the weekends than they do during the week. So, from a time standpoint, you can suggest training on the weekends. As a matter of fact, what my wife and I do, we have in the scope of our week, we have heavier days from a resistance training standpoint. We have heavier days and we have lighter days. The heavier days take the sessions tend to take longer, and we do that on the weekend. And then our lighter days, the sessions are way shorter and they're less intense. So we do that during the week. So for example, somebody could train lower body on Saturday, upper body on Sunday, and then a quick, light, easy over total body session during the week. You just got 3 sessions in, and you hit each muscle group twice per week. So that's one example. Also, our colleague Sheila O'Boyle likes to talk about those exercise snacks and just doing a little bit here, a little bit there, maybe 5 or 10 minutes of exercise throughout the day. That's not the greatest end point, but it is a great start point. And
Absolutely.
so that's another way to at least help to reduce time is let them know, hey, there's something called exercise snacks. You could actually just do 10 minutes of your time in the morning, 10 minutes of your time in the afternoon, etc. From a training standpoint, 30-minute sessions are an example. They don't have to be 60-minute sessions. So the fitness professional should include something like that within their fee schedule and the services they offer. And then from a money standpoint, there's again 30-minute sessions are going to be reduced in cost. Partner training or group training so that people share the cost. Um, the fitness professional can reduce costs by offering coupons or reduced cost starter packs or things like that. And then also virtual sessions is an option. And that's something that, the truth is, those who listen to the podcast hear the little commercial and they hear the intro, so they know that I'm plugging the virtual sessions that I offer, but I'm going to plug them again because it really is a nice, easier, lower cost option for patients. And another benefit to these virtual sessions, at least the way I go about it, is that I only sell 5 packs. That's it. So there's no pressure, which also reduces the barrier because they don't feel like they need to go into it purchasing 10 pack after 10 pack or 20 pack or something like that. There's no pressure. I just the main purpose of my business model is to create an informed consumer, to educate them, and to get them started on the right foot. So that's another low cost alternative. It's virtual, so it's going to be lower cost just by the very nature of it being virtual. And then also, it's just a consultation, 5 sessions. And if you feel like you've learned enough at that point, or you just want to check in on occasion, it doesn't have to be these ongoing twice a week sessions. You can do check-ins and things like that. So that would be my short answer to your question.
Sure. Yeah. And, I think there's something I want to add to this too, because the finance part of this is the one that I've dealt with the most. Physical therapists hate the idea of digging into the pockets of their patients. And
Yep.
so my mentor, Josh Lyons, who is the owner of Pinnacle, has this saying that he literally sometimes walks around our office saying, which is that affordability is a function of priority. And when he says that, it's affordability of cost and it's affordability of time. Am I willing to give my time to something? Am I willing to give my money to something? And our willingness to do that is truly a function of priority. And what we do by deciding whether something is in a patient's cost range, or making a judgment of how expensive something is, we are falsely prioritizing for them. And I think the best thing that we can do, and medical providers do this all the time in recommending medications that may cost money, in recommending other services or referrals to specialists that may cost money. We really just have to make the recommendation of what is absolutely the best for our patients in that situation. And if you believe that exercise should be a priority for someone who has early stages of hypertension, has the early stages of high cholesterol or metabolic syndrome, any of the symptoms of metabolic syndrome, who is maybe now in a place where they're dealing with type 2 diabetes, and we know that exercise can be a facilitator to reducing blood glucose and and stabilizing the metabolic system. If you know that that's something that can help, make the recommendation and let the patient decide whether it's a priority for them. That to me, I will die on. I will die on this sword that I will never feel bad making the recommendation of exercise to a patient and letting them know, hey, you know, the ball's in your court. This is one of the best things you can do for yourself. It has to be able to, you know, to fit into your lifestyle right now. And honestly, finances, I think, are a false barrier. And, you know, this is this is something that is not true in every clinic. It's not true in every community. Some people are truly working with people who are financially disadvantaged in a higher proportion of the time than others. But in a lot of communities, finances are what I would consider to be a false barrier. That people, when they really understand the value of what exercise could do for them, should be prioritizing this stuff as a means to prevent, you know, the big scary stuff that comes down the road from not doing anything. For on the other side of the big scary, just enjoying life a little bit more and feeling more fit and having, you know, a body that you feel good getting old in and enjoying your early life in. And, you know, there's so much of that I think we have to believe in the value of that, which I think is the lens that you were talking about, Jeff, in the clinics where they've referred really well to you. People just believe in that. So I think that's what I would say about the finance side in particular being a barrier, is that we too often make that the barrier, and we don't let people decide for themselves if that's truly the barrier. And if it is, then good. I mean, that we tried and they made the right decision for themselves, and they know that that service is out there now. But when we stop people from even hearing about the option, we're really doing a disservice to a lot of people who could benefit. So those are my thoughts on the subject. Anything else you want to say?
Yeah, one last thing, because I just want to interject and say I can't thank you enough, and tell you how glad I am that you just said what you said, because this is one of the primary, like, major things that makes you different. It's major. And in my experience, and also speaking with other exercise specialists across the country through my involvement in these various organizations, I know that what you just said is so true, and that this barrier is created because the clinician decides that, oh, my patient can't afford it. Well, you know, one of the things that Jeff Duran, who we had on the podcast earlier, who's the current chair of the board of directors for the Medical Fitness Association, one of the things that he says is that I wish all clinicians would just have, like, in the front of their mind, is that all you really need to do is get them to us for the initial consultation. That's all you need to do. Like,
Mm-hmm.
you don't need to even look past that. Don't even worry about it, because it's then you now pass the baton on to us, and it now becomes our job to to talk to the patient, who's now, hopefully a client, about how long they're going to train with us. And if that ends up just being a 3-pack or a 5-pack, and that's all they could afford, and one last thing, it's also part of the reason why I make sure that my initial consultations are educational. Again, what I try to do is create an informed consumer, and it starts with the consultation, so that the patient will learn things that they can take with them for the rest of their lives, which will benefit them right from the initial consultation. So even if that's all they can afford, they're still going to benefit. And I just wish fitness trainers did that, and not just did the stereotypical, I'm going to take you through a quick workout and some assessments. And the patient didn't learn anything. They didn't learn how to structure, and individualize a program. I teach all that in my initial consultation. So yeah, I'm really glad you said that, because all all they need to do, all clinicians need to do, is just get them to us. Don't worry about what's going on beyond that. We'll take care of that. And if it works out that they couldn't afford any more, then just a session or two, that's fine. But I'm so glad
Yeah.
that you said.
For sure. Well, and Jeff, despite our best intention to do a specific topic today, I still feel like we're just cracking the surface on some of this
Yeah,
stuff, man. And
absolutely.
this ended up being maybe a little bit more of a superficial conversation. We did get in depth in some of this stuff, which was great. We didn't get to some of the questions we were hoping to get to, but I think this was a good overview on when we're thinking about making a plan of care from the medical perspective, from prescribing exercise, from thinking about physical activity versus exercise in a prescription from a medical professional, how that can look like. I think you gave some really good insight, and hopefully, this subject we can come back to in a little bit different flavor, and come back to some of the questions we didn't make it to. Some of the stuff we wanted to talk about was, readiness to change of our patients and how we start to activate that a little bit, which is important. And some of the other barriers like fear of being judged and chronic pain, some of the stuff that's on my list, I'm looking over my shoulder at. So I think this set us up really good for a future conversation, but I think we're just scratching the surface on this stuff. And, I appreciate a lot your insight and expertise, you going through what you've gone through to get you to a place where you can speak on this stuff today. So it's been a good conversation. I appreciate it, man.
Yeah, absolutely. And I'll end with that. One of the things I love about talking with you and the fact that we're doing this on a podcast now is that we're showing that there's alternative ways to look at things and alternative views. It just seems like everybody has like the same view of how to refer or um, basically this continuum that we're talking about. Our experiences have been different, and the combination of us two and then talking about it, we'll be able to provide some different views and different ways to go about things that I am very biased to think that are a lot better and easier actually too. So thank you for the talk, Thomas. I really appreciate it.
Yeah. All
All
right,
right,
man.
so we will build on this in future ones. Do you need assistance in connecting with a fitness professional in your local area or virtually to add this connection to your patient services? If so, please email mrfinstituteorg@gmail.com and we'll be happy to guide you to this connection. Please also remember to check out mrfinstitute.org for information on how to learn more about the education we offer and to stay current with our podcast series. Thanks for tuning in, and we'll see you in the next episode.